Hello everyone, thank you very much for joining the call. I hope I'm going to answer those questions that you've just been presented in the Slido. It's like being marked, so we'll see how I do. My name's Tanya Pankhurst. I work at the hospital. I'm a renal doctor, so I use these systems all of the time. And I'll show you a bit about what we do. We build them, and then we utilise our data to try and make sure that we safeguard the safety of people that we're looking after in the trust, and make this convenient and helpful to the healthcare professionals, so that that things go smoothly for people who need to access our services. Next slide, please. Just a short introduction to the hospitals. So Queen Elizabeth Hospital Birmingham is the original hospital, and we've now merged with the other hospitals across the city, Heartlands, Good Hope and Solihull. This makes us a very enormous trust, and you can see some of the stats there on the slides about quite how many patients we look after across all of our sites. The original hospital, Queen Elizabeth Hospital, is where the digital healthcare comes from, and one of the main reasons for the merge, in fact, was to make sure that we could spread the good practice across to our other hospitals as well. So a lot of the things that I'm talking about now exist in the Queen Elizabeth Hospital, and we're soon going live with all of that across the other sites as well. Next slide, please. So in this talk, what I want to talk about to start with is the design of electronic healthcare records and the user interface. Then I want to move on to telling you about how we use the data to inform ourselves, each other, our patients, our colleagues out in the world. And then the last part, probably the most interesting part of the talk, is about how we transform individual and organisational behaviour on the basis of this kind of data. Next slide, please. So the crucial points are using clinicians to design the user interface, and I'll talk about that, how we prioritise and mandate the use of these systems, and then something about all of the surrounding things that you need to be concentrating on, like hardware, operational nature of how you run a hospital, and then how you can exchange data across the patch beyond the hospital boundaries. Next slide, please. So UHB employ a team of programmers. It's very unusual for hospitals to do that in this day and age. So we're like a little mini software house building our own electronic patient records within the organisation. That's why it's so interesting to do my job, because I basically get to be involved in the team who are building the records. We don't just buy this ready-made from somewhere else. We get to design it ourselves. Clinicians lead the project. That's crucial, because the clinicians are the end users of the patient record within the hospital, and our patient groups design the patient portal, which I'll touch on briefly. So the end users are the people who design the system. The clinician part of this, the records, the clinicians are derived from all specialties and disciplines, and I'll go into that in a little bit of detail. And the leads for the electronic patient record are doctors, and have some of their job plan time in the digital world, but most of it's still in clinical practice. So, if we design this badly, then we have to use it too. The other crucial thing is that the leadership is from very high up in the trust, from the executive level, and the medical director is the person who oversees the entire programme. So this gives us a good mandate so that people don't opt out of its use. Next slide, please. So here we are, the executive chair at the top, the medical director, quality development leads who are doctors throughout the organisation. They all group up in a clinical design advisory group so that we can have an active discussion all the time about the design. And then across the nursing, they've also got their own clinical design advisory group from nursing leads across all divisions. Allied health professionals have their own. The pharmacy and drugs are controlled by pharmacy and drug groups as well. So you can see that a lot of people, a lot of end users are involved in this design. Next slide, please. Paper records have worked for years, and they've been honed over decades and decades. So if you suddenly throw them out and then design something completely different, that probably isn't going to go down very well with clinicians. So lots of the record is actually based on, the home design of paper records that has been going on for years. Some things are much better though with electronic records, of course. You don't have to duplicate data over and over again. You can put it in one place and then copy it by the computer into other places. Filing is much better, and traceability and transparency in electronic systems is obviously very good because you've got an audit trail and people can't pretend that they wrote something when they really wrote it a long time later on. We know that from lots of feedback, these systems need to look like the original notes and be easy and quick to access. So our design principle is minimal disruption, but maximal intuition. We need organised information at a glance, which isn't overwhelming. Next slide, please. And so here we are. This is these are not real patients, by the way, just to qualify that. This is all made up patient data, but you can see that the records present lots of information. So here you see lots of symbols and things that you can hover over to find out what's going on with these patients. Next slide, please. We know that in terms of putting data in, if it's easy to put in data, then it will be put in. So we start with the user interface, not the data itself. If you decide you want to collect lots and lots of data, and then you design an electronic record that's not relevant to the patient or the clinician, particularly at the point of care, then both the patient and the clinician will just ignore you. As I keep on saying, the system is designed by the clinicians, not by the programmers. And we know that in a lot of research and a lot of electronic patient records put hundreds of alerts up in front of clinicians, and this just means that you don't read them properly. So you have to design this properly. Next slide, please. So, for example, you can put lots of things into records to help. You can have data entry via sliders, like you can see in the bottom one here. You can put in numbers, and then you can use diagrams. You can use places where you can click on things to fill in various forms. In the diagram here of the eye, for example, there's a slider underneath, which I can't demonstrate in a flat slide, but in the record, you can slide that around and the pupil will get bigger or smaller. So you can match the picture to the patient in front of you. Next slide, please. Lots of things about electronic records obviously just get much neater. There's the old paper chart on one side and the nice neat electronic chart on the other, so that you can present data really properly. But you need to do this in a really sensitive way, because there are lots of electronic ways to present data and actually can confuse your users rather than help them out. Next slide, please. When you're trying to manage lots and lots of information, these are the ITU charts, for example. You need to be sensitive about how you're going to do this. So when we designed our ITU charts, all of these sections can be moved around, which you couldn't do in the old paper chart, obviously. So if you're a neurosurgeon, for example, you can put the neuro observations right next to the ventilator observations, and you can see how your patient's doing related to those two things. If you're a cardiac surgeon, you might want to put the blood pressure and so on next to the ventilator obs to see what's going on. So electronic records, which are designed like this, can present lots and lots of information and make it relevant to the user in front of them. Next one, please. We're not very interested in defining rigid care pathways. So lots of electronic patient records are now developed like this, where you tick lots of boxes and then it tells you the answer at the end. The trouble is that most of very complicated patients in tertiary referral centres don't follow the rules, and you'll end up with a lot of rigidity in these kind of systems. So what we try and do is present the users with all the information that they need, and then when they're trying to do something within the system, if it seems really, really crazy and outside of normal practice, we'll say, are you sure? Are you sure that's right? Rather than putting people on a single rail and forcing them to do one particular thing. This is a way of avoiding error and not creating over-reliance on the system. And it's also a way of making sure that users can use the systems even if patients aren't completely conforming to exactly what was expected. Next slide, please. So one of the big questions then about how you're gathering all this data is how you're going to use it. So for example, for direct clinical care, we and driving clinical decision support in the moment with immediate clinical consequence, we need to present the data in a different way than data that we're trying to give back to the organisation for its own awareness and understanding. We know that in clinical records, coded data is generally more useful than text because you can reprocess it and you can create big data sets with it. And we know that scanning is generally unhelpful because at the current time, we can't use a lot of scanned or photographed text very easily for putting that back into big data sets. Next slide, please. There's some other things that I just want to briefly touch on outside of the EPR. For example, hardware and access is critical, and you'll hear lots of reports across the NHS for the fact that doctors and nurses are frustrated because they just don't have a computer. If they do have a computer, it doesn't work very well. The Wi-Fi doesn't work. So, for example, when we put in a method of being able to order bloods on patients by scanning their wristbands, if the Wi-Fi didn't work in the room that the patient was in, then that would scupper the entire project. You have to have big enough screens, for example, in ITU, and as you make a really good EPR, more and more people want to use it. So you constantly need to keep on having more and more computers, tablets and devices with correct interfaces for your users. Next slide, please. So lots of different bits of kit, and even this slide is now out of date, right? Because we're right in the middle of the technology age and things are coming online all of the time, which creates easier and easier user interfaces. Next slide, please. Yeah, this slide is just to remind everybody that, you know, we can build the most beautiful systems in the world, but there are lots of things that you can't fix just using digital systems. So if your operational structure is wrong and the process in the hospital doesn't really work, you can design the most beautiful thing to go on top of that, but the operational process is still bad and you can't fix it just by putting a shiny, nice computer on the top of it. Next slide, please. Okay, so then interoperability. Of course, now we are being able to move data around the system much more. And, you know, understandably, patients are demanding the fact that, you know, if they go to different healthcare settings, they ought to be able to have access to all of their data. In order to move data around, we need to be collecting it in the same way. So we want to standardise diagnosis, for example, using SNOMED codes. We want to standardise messaging using HL7 or more recently FHIR. The interfacing of software needs a discussion with suppliers, and suppliers are now really coming on board this now about information exchange. It used to be that suppliers used to deliberately make it very difficult to exchange data so that you had to buy their systems, and that's becoming extremely old-fashioned now. You have to have a very good eye on information governance, of course, because this is highly sensitive data. Now we want to stream data from devices, so lots of things across the hospital that we're collecting lots of data on that we want to put inside the record. And indeed, patients start to collect their own data using smartwatches and so on. We've got very large data sets now, for example, genome data sets that we want to integrate into the record. And then when we're starting to exchange these data sets, we just need to be very mindful of what minimal data sets we're exchanging. For example, in allergy, if you collect allergy in 5 different categories and I only collect it in 2, then those 2 data sets are extremely difficult to exchange. Next slide, please. Okay, so that's the section on design then. So I want to move on now to think about how we use all this data that we've collected to inform ourselves and each other. So how do we do this? How are we using this for direct patient care, for operational efficiency, for clinical dashboards, junior doctor dashboards, informing our patients and informing our colleagues? Next slide, please. So we need to be able to extract the data from the EPR all of the time. But as you know, once you start to extract large data sets from pieces of software, you can slow down the software itself. And then we're back to one of the design principles that the software has to be extremely fast for people to be able to use it. So we overnight download all of the data into SQL database for reprocessing the extraction by our informatics teams for things that we don't need instantly. But of course, there are a bunch of things that we do need instantly. So we've got both a 5-minute feed and an immediate action feed off the EPR. Next slide, please. So for immediate action, for example, in a deteriorating patient where you need an early warning score, you can both alert within the system and you can send out to external devices to get emergency teams to turn up at the bedside immediately. We need to know our immediate bed occupancy. And then, for example, there's lots of ways of messaging out of the EPR. For example, when a patient becomes very low in sugar, the diabetes team want to know, the safeguarding team wants to know when a vulnerable patient is admitted to the hospital, the transplant teams want to know when patients are too sick to be transplanted and should be suspended temporarily on transplant lists, etc., etc. You can also start to triangulate data sets. So for example, if we've got a system telling us when appointments are due, we've got a system telling us when imaging has been done on a patient, we could then triangulate this data with the patient data that we've got in the central records and make sure that patients aren't missing their appointments or what's happened to this patient who should have come for this scan. Next slide, please. For the operational performance for the hospital, obviously the hospital has very many targets it's trying to meet. The emergency department is constantly running on various different alert structures, and we meet series of targets across the hospital. We also have our own external and internal quality improvement strategies, and all of this data can therefore be fed back into all these various places in order to performance manage the hospital. Next slide, please. So here's an example of our clinical dashboard, which I'll return to in more detail later. Next slide, please. And we also triangulate our data, for example, to understand our junior doctor behaviour. And again, I'll return to these dashboards in the last section of the talk about behaviour. Next slide, please. We process all of our data and send it out to inform our patients. So this is an example of the patient portal where anything that we're putting into the electronic record in the hospital, we can represent back out to the patients. Obviously, this needs to be done in a way that everybody will be able to understand. So we, for example, here you can see we present medication, lab results, all of your recent letters and upcoming appointments. It's an interactive system so that patients themselves can upload information and then that can be sent back in and put onto the the records within the hospital. So it's a kind of two-way process. Next slide, please. We utilise data within the hospital to inform people whilst they're in the hospital what's going on. Next slide, please. We send all of the data out to the GPs, of course, and allow GPs to be looking at data related to their specific patients. Next slide, please. And now we are collaborating at the moment on the Health Information Exchange, which is actually one of the most exciting new developments, along with the Cancer Alliance and the Regional Image Sharing Platform. And these projects actually really start to, for the first time, exchange proper data across the whole of the region. So in the first instance, we will send diagnoses, medications, end-of-life decisions, results and images region-wide, so that really you can start to turn up in various different health settings and have your data provided there for you. These obviously require massive collaboration across regionally across very many healthcare organisations. And once the regions are sorted out, then of course we can start to join the regions and have a proper national sharing platform. Next slide, please. All right, so just the last part of my talk then. I now want to talk to you about how, having got all this data and presented it back, how can we look at individual and organisational behavioural change? Next slide, please. So first of all, we use clinical decision support within the system itself. So because we've got so much data, we can, next part please, we can start to use this to help decision making at the point of looking after the patient. So in this first example, the patient has been screened for this horrible infection called MRSA that everybody's heard about in the news. The patient's positive for MRSA, and we know that there was a gap between a positive result coming back and the patient being treated for this. We know that most of the treatments for MRSA, if we know about patients' allergies, are safe to give. So in this example, the system starts the cream and the eradication therapy that you need to be giving without a doctor having to write all of that up. So this has completely reduced the time for patients to be treated for this horrible infection. In the second example here, there we go. In the second example here, we've got a predictive tool. So here you put in a series of information, and the software starts to give you advice about what to do next. Next slide, please. And in prescribing, obviously, we use these tools heavily in prescribing. So we can give simple messages. You can see at the bottom of here that paracetamol tablets come as 500 milligrams, or one tablet comes, 2 tablets is 1 gram. Next slide, please. You can use it for drug interactions and allergies. So where in this patient, you're being warned, are you sure you want to give this? This patient appears to be allergic to aspirin. And in the third example, you can use comorbidity. So this patient, is known to have something wrong with their liver. So please don't give this drug to the patient. Next slide, please. So, for clinical decision support, this is providing an individual tool, obviously, between the user and the patient when you're actually doing these actions. So now I want to tell you a story about how, though, can we start to influence change across the whole of the organisation. So in this example, the organisation decided that it wanted to reduce the number of missed antibiotics within the whole of the organisation. So in the first thing that we did was we provided the data back to users. Next slide, please. And this is where the clinical dashboard comes in. So in the clinical dashboard, we said by a lot of information messages out to the organisation, we're interested in why we're not giving antibiotics all of the time that they're prescribed. We prescribe them, right? There's a reason for prescribing them. They shouldn't be missed. In your ward, we appear to be missing antibiotics quite a lot of the time. So we presented this clinical information back via these dashboards. Next slide, please. All right, so once you've started to give people the information, then people say, okay, everybody's taking this seriously. We want to try and reduce antibiotics. We understand that the antibiotic missed doses. We understand that this is important. But then you need to be careful, because you need to allow your people to reinforce the change and understand what the barriers are. And you need to make sure that all team members can affect the change. So this is the nurse who's giving the drug. This is the nurse in charge of the ward. This is the doctor who's prescribing it, and etc. And not only do these clinicians need to be allowed to know what's going on, they need to be able to speak to somebody in high command who can do something about this. So this is a picture of one of these real meetings where the then executive of the entire trust, the chief executive of the entire trust, is sitting here opposite the clinical team, and flanked on either side of her, she's got all of her executive team there. Now, this means that the nurses, the doctors, and everybody else on the ward can say, yeah, well, we'd love to give these antibiotics, but, they're not in the cupboard, or the porter won't get them, or we don't understand, the pharmacy didn't supply them, and so on. And of course, given that this is, the chief executive, all of those pathways are suddenly much, much easier to iron out. In fact, when this process was first put in, the CQC wondered whether, the clinical teams felt bullied by this process, and they started to ask questions about the organisation. But the clinical teams in general came back and said, no, they wanted to keep these RCAs, they wanted to keep these processes, because for once it gave them a direct line to the top of the organisation to talk about why things had gone wrong. And you can see in this graph that when you can see two-step changes in this graph. The first one is when we start to present the information back to the organisation, so people start to realise that, you know, it's an important thing. But the second big step change is when you actually have these RCAs and you start to really do something about it. By the way, there's just an observation here that actually at the same time as this project was going on, the mortality in the hospital appeared to fall as well. Now, whether these are really related things or not is unknown, but it's interesting that antibiotic misdoses and a real kind of focus on them did appear to also reduce the mortality in the hospital at the same time. The other thing that happened that we looked at the time of this project was we looked at systems in other parts of the region. So these are other electronic patient records where, you know, similar things were in place in terms of clinical decision support, but these other processes, these operational processes on top of the digital systems weren't being done. And you can see the comparison to the percentage of missed doses that were being forced down. The other thing you'll note that on this graph, this is non-antibiotic. So this wasn't even what we were going after, but you can see that, you know, you have a halo effect. Once you start discussing antibiotics, you also have a reduction in non-antibiotics as well. All right, so the second story I want to tell you is about the junior doctor dashboard. So the junior doctor dashboard uses patient data from the clinical system, the PIC system, as I've been telling you before. And this identifies junior doctor behaviour. It identifies outliers. So what junior doctors are doing in general, and then what they're doing a lot of or little of. And in this project, junior doctors were then asked to attend meetings with a consultant to review the data that was being shown about their behaviour, to discuss their performance and why that was happening, and then agree an action plan for improvement or not. I mean, if they were outlying in an excellent way, then obviously that data was taken back in for understanding how that could, how the rest of the doctors could be made to behave in the same way, and identify and share good practice. So there are lots of examples of this, but I'll just tell you one story to show you. So these are three individual doctors. In the blue bars, you can see the before, and in the red bars, you can see the after effect of this project. So in hospital, we know that once you get into hospital and get stuck in a bed, your risk of getting clots in your legs increases a lot. And those clots can fly off and get stuck in your lungs, which can cause well, first of all, it can cause death, but it can cause a lot of morbidity as well. So in hospitals, we try and prevent this by prescribing blood thinning drugs to prevent these clots from happening. We force you as a user in our EPR to do an assessment of every single patient who comes through the hospital about whether you need anticoagulation or not. But we know that even if we tell you to give anticoagulation, sometimes you don't do it. Now, and why is that? So we asked these three doctors, look, why when you're asked by the system, do you hardly ever do this? So one doctor never does it. One doctor only does it 15% of the time, and the other doctor does it less than half the time. Why is that? Now, these doctors are all good doctors. They're very caring. They really care about what happens to their patients. And they say, oh, you know, this is a bit scary, this drug. It can cause bleeding and la la la. So after discussion, they all agree that actually by omission and leaving the problem to somebody else, they might be causing just as much harm as getting on and deciding. And they all convert their behaviour. And so afterwards, they nearly always prescribe these drugs. And of course, the reason why we can't automatically prescribe them is in some patients it's dangerous, and so they shouldn't be prescribed all of the time. So then we looked at all of the doctors' behaviour, and you can see on this scatter graph, all of these little dots represent doctors. And if the doctors were all doing what they were told all of the time, all the dots would be at the bottom of the graph. The more you prescribe, the more patients you affect, the further along the x-axis you come. So in an ideal world, all of these dots would be at the bottom of the graph. Now, after we'd started these junior doctor clinics, they all started to talk to each other and say, oh my goodness, you know, they're watching, we better watch out. And, you know, you better do what you're supposed to do with this enoxaparin. And all the dots start to move down the graph, but they didn't all get to the bottom of the graph. So then we did something else. we made a change in the PIC system as well. So we said, okay, guys, the system is going to propose what you ought to be doing with this enoxaparin, and then we're going to freeze all your prescribing rights until you've made a decision. So either you prescribe that drug or you delete that drug, but you can't do anything else with prescribing. Now, of course, we didn't freeze the rest of the system, so the nurses could carry on administering their drugs, and blood pressures could carry on and noting could carry on, but prescribing couldn't carry on until you'd made a decision about this. And then all of the dots are squashed right down to the bottom of the graph. So I think this is a really good example of how, with operational overlay and understanding your data and communicating with your organisation, you can then use digital systems on the top to really finish off affecting that change properly. Okay, so I hope in this in the short talk then I've showed you that design of electronic health records is extremely important, and it needs to be thought about in terms of delivering quality of care. I also hope I've shown you that information is powerful, and letting people see their data will change their behaviour. And then I hope finally I've shown you that transformation of behaviour requires knowledge and then process change very carefully in order to really look after and care for people properly.